My name is Dr. Edward Ngwenya, and we continue with our plastic surgery podcasts. Today's topic for this will be continuing with the lower extremity. And in this series, or rather this episode, if one may say, we will be focusing on lymphedema. So I think, as I always mention, remember, you've got to read it for yourself. You've got to understand the basics. You've got to understand how the normal system works. The anatomy that then I refer to, the physiology that then I refer to. And once we understand that, we can then understand the pathophysiology. In other words, how problems happen, where they occur, and knowing the anatomy will then be able to then intervene for this patient. So let's just quickly go into it then and speak about lymphedema. So what is lymphedema? I think to succinctly define it, it's a build-up of proteinaceous fluid within the interstitial compartment. And this is secondary to abnormalities in the lymphatic transport system. So what is it? A buildup of proteinaceous fluid within the interstitial compartment, and this being secondary to abnormalities in the lymphatic transport system. And this will then be characterized by local or systemic failure of lymphatic transport within this system. So this is something that is generally quite common, actually. Most commonly affecting the lower extremity. In fact, 90% of the cases will be the lower extremity, then 10% being the upper extremity, and the genitalia forming 1% of these. And the incidence is generally quite high, mainly iatrogenic. Especially if you look at it after mastectomy, we're looking at about a 24 to 49%. That's almost half chance of having lymphedema. And when you have instead a lumpectomy, you still have a 4 to 28% chance. And when you have a sentinel lymph node biopsy, actually, there's a 5 to 7% chance of getting lymphedema. So this is something that is quite common, especially when, we deal with malignancies in those specific areas, melanoma, any, genital urinary cancers, head and neck cancers, making least of those 4%. But of course, the extremities, we know we get your cutaneous and your sarcomas, that being 30%, chance there, or the incidence of getting lymphedema. Now, as I always refer back, embryology is important. Anatomy is important. I'm not going to spend too much time on this, but I would just like you to understand that the lymphatic vessels specifically develop from the venous system embryologically. So what you'll get your lymph sac bud that would come from the venous endothelial cells, and then these will coalesce into primitive lymphatic capillaries. And so then a rudimentary lymphatic system will then be established generally by the end of the second gestational month. And by the 5th month, generally, we would be able to appreciate and see valves in the lymphatic system. So remember, when we speak of this lymphatic system, we come from lymphatic vessels, the lymph nodes, and the spleen that would then come, and all of these are derived actually from the mesoderm. Anatomically, the lymphatic system can be divided into three. There's the superficial system, the deep system, and the visceral system. The superficial system, of course, we know that is the suprafascial part, which is within the subcutaneous fat, and this generally is what would drain the skin and the subcutaneous tissue. And you will see when we, do cosmetic operation, example, one of the things when you do an abdominoplasty, others would then maintain the scarpa's fascia, believing this would decrease your seromas by preserving your lymphatic channels. Then we've got the deep system. Now, this is subfascial. And this is the system that accompanies the blood vessels. This would drain the muscles, your tendon sheath, your nerve, your periosteum, your joints. And this is now the main deep system that the superficial would also then drain into. And then, of course, around our intestines, our spleen, liver, even the lungs, and the thymus, there's the visceral system. And this, it is quite characteristic as the lymph from this, intestinal, or rather visceral system usually appears milky. Why? Because this is generally due to the fatty acids that are absorbed from the gut, and that's why we have this chyle, this milky lymph that comes from the visceral areas. So now, of course, I've mentioned the different systems. Of course, between the superficial and the deep, these must be connected, and they are connected by perforating lymphatic vessels, and those would connect now the superficial and the deep. Just to make mention that in between there are also different connections, or rather, sites where they would drain, and these would be the inguinal region, the popliteal, lower down the cubital. So these are other sites where lymph will then drain into. Remember, we've mentioned we've got our channels, we've got now the nodes, and then after they've collected therein, so you can imagine, these lymph capillaries, which are valveless, they then would collect this lymph in the pre-collectors, and directly then lead these into the lymph nodes, and from the lymph nodes we then go into the lymphatic trunks, which are quite large, about a 0.1 to 0.6 millimeters in diameter, and they would generally resemble other vascular structures. How so? They have an intima, a media, and adventitia, and these trunks are have a valve component. So these would have valves, and generally, within 6 to 20 millimeters, you then have valves. Now, remember, there's a segment that is between the valves, and these we call the lymphangion. Now, this area, they are supplied by, autonomic nerves, and contraction would then be initiated therein. So you have lymph that accumulates there, and that would be propelled by this contracting mechanism, as the valves then open from one valve to the other valves. And remember, I've mentioned we've got our system coming in superficial, deep, through the perforators to the lymph nodes to the lymphatic trunks, and from them we have two major trunks, the left and the right lumbar trunks, which would drain the lower limbs, the lower trunk and the external genitalia, and this would then join the GIT trunk to form that body, or that trunk that we call the cystina chyli. So this is that thin-walled, trunk that's located anterior to about T11 to L2. And then this would enter the thoracic duct, which is the largest lymphatic trunk. I mean, this is huge, up to 5 millimeters in diameter. And this would then run cranially from the cisterna chyli, remember we mentioned, along the aorta. And this would then empty into the left internal jugular and the subclavian veins then subsequently. Remember, from this whole physiologically, about 3 liters of lymph will empty per day into this junction of the left internal jugular and subclavian veins. And of course, we don't want reflux. So therein, you will find a valve that will prevent this reflux, of blood into the lymphatic system. What else have we not mentioned? Of course, there's the right lymphatic duct, which is formed by the confluence of the right jugular, supraclavicular, and subclavian and the peristernal trunks. And this is generally short, about 1.5 centimeters in length. And this would also then drain into the right internal jugular and subclavian veins subsequently. But of course, knowing the left trunk being that the largest therein. I'm not going to get into the physiology of the lymphatic system. Suffice to say, it's a draining mechanism. We don't find it in the central nervous system. It does not drain, when you look at the muscles would not contain the lymphatic system. However, they assist with the propulsion thereof. One example being the gastrocnemius supplied by the sural nerve, and you can then, with walking, mobilizing the two actions of the lateral and medial belly of the digastrics, assist with lymphatic circulation, as the limbs, have a lower pressure. And so you want to get it on a higher pressure coming up there. So why do we get lymphedema? What is the pathophysiology now that we understand the normal physiology therein? I think to simplify it for you, what I'd rather say is that what happens is that lymphedema will generally occur due to insufficiency of the lymphatic system. Now, this will happen via two mechanisms. And may I then say herein that these may coexist with each other. And what are these two mechanisms? It's an issue of capacity, number one, the lymphatic system itself. And the other side versus the issue of load, that there's too much load. So we divide these into high volume insufficiency and low volume insufficiency. So what is the high volume insufficiency? Basically, this is when the lymphatic load exceeds the transport capacity of an intact lymphatic system, and this may then result from chronic simple edema. And then we've got the low volume insufficiency, which is basically reduced transport capacity that it cannot deal with normal quantity of lymph. So lymphatic quantity is normal. However, the transport capacity cannot deal with that normal load. So this is low volume insufficiency. And so this then, takes on its own course, and the natural course therein would be, if left untreated, lymphedema will then lead to stagnation of water, of proteins, of waste products, and all of these will accumulate in the interstitium. And by that then happening, having this proteinaceous fluid, this edema therein, it would then cause tissue damage. And so you will see, as we describe the stages, of course, whenever you have an increase in diffusion distance, you're definitely going to have problems with perfusion. But not only that, you will also impair the circulation of macrophages and lymphocytes, and then further increase the susceptibility to infection. So not only the damage from the proteinaceous fluid, but the gap then decreasing perfusion, also limiting the macrophages and the lymphocytes from reaching. And so these patients would have episodes of cellulitis and lymphangitis, which would then in itself now start to damage the lymphatics itself, leading more again as this vicious cycle continues from, to the high and the low volume insufficiency. So this is quite a vicious cycle that then happens. And there are stages that this would then happen. And so we then, in view of this, then stage lymphedema into 4 stages. And this was designated by the International Society of Lymphology. And what are these stages? Remember, I've mentioned the pathophysiology, so now walk with me as we define now the stages. Stage 0 would be subclinical, the subclinical stage. What then happens in the subclinical stage? We have, basically, we've got lymphedema. However, there is no edema that is evident. But we know that already we've got lymph transport that is impaired. And this can occur over months and years before you get, overt edema. So this is just a latent subclinical condition where we've got a problem with the transport system. However, clinically, we do not have the manifestations thereof. Stage 1 then comes in, which is the reversible stage. Reversible in which way? Now we start to have pitting edema. We have this early accumulation of this proteinaceous fluid with edema that is there. However, how do we distinct it? How differentiate it? How do we know? Why do we call it reversible? Because it resolves with limb elevation. So when you elevate the limb, then you will see that no, actually this responds and it resolves. But then we move to stage 2 now, where there's, spontaneously it's irreversible. So here we have pitting edema that, may or may not be there. But what is characteristic is that tissue fibrosis starts to develop. And when you now elevate this limb, limb elevation on its own will not resolve the tissue swelling. So now this is spontaneously irreversible stage. Then we move to the final stage, stage 3, which is the lymphostatic elephantiasis is the other way that we call it. We call this, elephantiasis. You've got this lymphostatic, elephantiasis, and this will happen, with absent pitting. It's quite characteristic, There's acanthosis, there's fat deposition. You have this, call it warty growth, and you may have other trophic changes in the skin occurring. So once you have this, we are also further able to then assess the severity therein. And how do we assess the severity within each stage? So within each stage, you then group it as mild, moderate, or severe. And basically we assess this by volume. So we look at the volume and we say mild if there's less than 20% excess lymph volume, that's mild. 20 to 40, it's moderate. And more than 40, there's excess, there's severe, grading in that regard. So this is how we stage it, and this is how we then grade the severity therein. So when then I ask you, how do you classify lymphedema? You will then tell me that it can be classified either based on the etiology as primary or secondary. So the causes therein may be primary or secondary. That's how we classify lymphedema etiologically. Now, what is primary lymphedema? Primary lymphedema, we are looking at the primary causes, and we can put those as three. One would be, your lymphedema congenita, which is also known as Milroy disease. And that's 15% of the cases. Then there's lymphedema precox, which is also known as Meigs disease, and this is familial lymphedema precox. And then there's, and by the way, we'll get into it because it may also present at puberty. And then we get lymphedema tarda, and this generally happens after, 35 years of age. So congenital, precox, and then lymphedema tarda, which would happen then later. And then there are other secondary causes. What are the secondary causes? They can be classified, using a mnemonic. I like to use the 5 I's. The first I being invasion of tumor. So you can get primary lymphatic tumors that then occur. What are primary lymphatic tumors that you can think of? Your Stewart-Travis syndrome, which is generally a rare angiosarcoma that develops in people with long-standing lymphedema, and Stewart-Travis syndrome specifically after modified radical mastectomy. But you may also have secondary tumors that may cause this. In the other eye being infection, and the most common worldwide cause is filariasis. This one, we're not going to get into, but a common drug which is in our setting now with the COVID that had come in, the corona, the drug that comes that everyone has been mentioning and much controversy, being ivermectin. And ivermectin is one of the drugs that specifically we use for filariasis. And then you can get lymphedema, infective secondary to TB, lymphogranulomas, and then the inflammatory causes, from snake bites, burns, insect bites, irradiation is another cause, and any iatrogenic causes. What's iatrogenic? The number one, generally lymph node dissection for malignancies, or people who, do stripping for varicose veins, chronic venous insufficiency, and more causes, from obesity, trauma, etc. Now, let's perhaps just get a bit deeper into the primary causes. I'm just going to try to stay high level, in the primary causes, because there are many. You can even think of, your tuberous, your Noonan's, your Turner syndromes, which can also be included, under the congenital causes. So lymphedema congenita, which is Milrose disease, generally, being the second most common type of primary lymphedema, it's usually present at birth or within 2 years of birth, and the lower extremity being more affected. It's 2 times more common, in females, and generally patients would present with bilateral lower extremity lymphedema, a 3-to-1 ratio, lower versus the upper limb. And this can be associated also with intestinal, lymphangiectasis, and even cholestasis, we found in these patients. Lymphedema precox, which is the most common and autosomal dominantly inherited disorder, usually presents at puberty, and it's also more common in females, actually 4 times more common, and that's why we think there may be an estrogen component in the pathogenesis therein. And these patients, some of them, have been given tamoxifen as a treatment, and they generally are associated with multiple anomalies. They may have vertebral, cerebrovascular, hearing loss. They may have, this double row of eyelashes that's known as dyschiasis. And generally, these patients would have unilateral, lymphedema affecting the foot and the calf. And then later on in life, usually after 35, the rarest form is lymphedema tarda, in 10% of the cases. Histologically, lymphatic system is often tortuous, it's hyperplastic, and you're not going to see valves in these patients. And generally, it's a diagnosis of exclusion when now we've looked at all other causes, and we cannot find anything. And usually you'd find a familial pattern in this regard. So now that we've gone through that, the next step would be looking at, a patient coming in with lymphedema, and would say then diagnose this patient for us. And what you then want to do is do a, whenever we say diagnosis, the first thing you need to say is, on history, this is what I'm going to ask. On physical examination, this is what I'm going to do. And when I then direct my investigations, these are the investigation modalities that I would employ. And on history, we look at all those things as I've given you: family history, you look at primary lymphedema, looking at the onset, and trying to follow, whether there was a positive family history that may occasionally be there. And then would look for other secondary causes. Remember, we spoke about them: trauma, surgery, radiation, etc., or 5 R's. So you look at all those causes, and then you then go in and look at other causes, signs of venous insufficiency, DVT, renal failure, congestive heart failure, and you try to rule all those out as causes that may give you lymphedema, because those are other causes that may give you bipedal edema, or limb swelling, rather. And so we do our physical examination, and generally lymphedema is quite distinct. There's a doughy swelling of the extremities, and the test that we generally would do is a stemmer's test, where you try to pinch the base of the second toe, or second finger, but second toe generally used, and you find that you are unable to do that. That's a positive stemmer's sign, and generally you diagnose lymphedema with this, looking at the limb, looking at dermal changes. They have this pure de rage, as you then start to have dermal fibrosis, and you may then start to measure the limbs and grade the severity therein. And perhaps I can quickly just touch on this while here, that it's important to separate this from lipedema, very important. What is lipedema? Lipedema is now the swelling where it's actually just lipid on the lower limbs. And how do you separate this or differentiate it from lymphedema? Generally, characteristically presentation, it's mainly in females only. That's lipedema, whereas lymphedema will be in both. And the age of onset generally will be, around puberty. There's generally a family history with lipedema. Obesity is generally there. The patients are generally obese. And it's always symmetrical. The one main differentiating thing that you can look at and that I generally look at are the limbs. The feet. And the feet are generally never involved in lymphedema, whereas in lipedema, they are always they are never involved. So in lymphedema, it's everything, whereas in lipedema, you will never, the feet are never involved. And so you'd look then at other signs. Bruising, is it tender? Generally, lymphedema is not tender, but lipedema may be, painful there, and there may be a lot of bruising, which often one would see, and the tenderness that's there. And you may do tests where you would then see the fat appearance with lipedema, whereas in lymphedema on CT scan, on MRI, you would then be able to pick up your honeycombing as opposed to just hypertrophy of the limbs themselves. So this has already led us to diagnostic tests for lymphedema. This was just on a side to make sure that you are able to separate it for lipedema. Now, what are the diagnostic tests that we can use? There's contrast, lymphangiography. So we can move from invasive and non-invasive tests. So non-invasively, you can do those. There's also, CT scan, which will show the honeycombing, but it does not necessarily, give you a good characteristic view. And so MRI, is a good one that will provide details about the lymphatic trunks, the nodes, and you are able to then follow the channels. Isotopic lymphoscintigraphy is one that's, commonly used, one of the most commonly used diagnoses. But of course, one thing that you must know, if, you inject anything on the toes, generally in the first web space, if there's an obstruction, you're not going to see it going up all the way. The same with, your contrast lymphography and your indirect, which would be intradermally, whereas the direct, it's into the lymphatic system, which, may cause problems therein, having, a worsening of fibrosis, and you may have adverse reactions therein. I think we can go into the treatment and say, how do we treat lymphedema? What you then need to then know is that we've got various modalities. We've got conservative, treatment, and then we've got medical treatment, and then we've got surgical treatment. So what's the conservative non-surgical treatments we may employ? The main benchmark of these, besides, the reduction in body weight, avoiding to gain weight, they generally don't have good scientific evidence, but the benchmark is complete decongestive therapy. CDT, and that's the Foglis technique. And generally, this would be administered by a certified lymphedema therapist. And there are two phases: the reductive phase, which would begin in the first 3 to 8 weeks, usually done in the hospital, and then there's the maintenance phase. Just watch a few YouTube videos if you haven't seen how this is done. Generally there's manual drainage of lymph. There's therapeutic exercises. It involves skincare, education itself, management, elastic compressions, and these would be carried over, lifelong. For self-lymph drainage on the maintenance phase. And this has shown to work, actually. I mean, there's about a 40 to 60 mean reduction in excess volume in patients with pitting edema. So this is something that is generally quite good. Medical therapy, I'm not really going to mention much on it except, the antibiotics, doxycycline generally if we've got, long-term infection as prophylaxis, acute infection, augmentin for bacterial infection, or for, parasitic, the ivermectin, for the Wuchereria Bancroft infection, which is caused by that filariasis. Others, diuretics have been mentioned. I would say they should not be used to treat lymphedema. Why? You remove water, but not the protein. And so, it leaves this high concentration of interstitial protein, leading to fibrosis and inflammation. And also remember the oncotic pressure. So if you've got high protein concentration, what's going to happen? You're going to attract water where? Back into the interstitium. So those ones generally don't. There's the flavonoids, minimal reports. There's the benzopyrones. I'm not going to mention it, really get into it, as there isn't really enough evidence to support the uses therein. Additionally, you've got your hepatotoxicity side effects. So I'll generally stay away from medical treatments besides treating the underlying, bacterial infection or fungal infection. And so what options do we have? We don't really have much, I guess. Then we've got surgical treatment as then the option. And we divide surgical treatment into physiological and reductive techniques. The reductive techniques were those that were used quite a long time. They are a bit of a problem. They're not so reliable. What are they? They are direct excisional, procedures that you may do, or then you may use then liposuction as another modality. What are direct excisional techniques? There's the Charles technique. There's the modified Charles technique. What is that? You do a circumferential excision and then boop, you put a skin graft. Modified Charles, after doing that complete debulking, you don't immediately put a graft. You put negative pressure wound, dressings or therapy that you then use, and then you come back after 5 days or 7 days, and then you put a skin graft. There's the Miller procedure, where you only go on one side, and that's the one that's more commonly used. You do a longitudinal medial excision of skin, and then and you include, of course, subcutaneous tissue, and then you place, suction drain, and then you close, and then you keep coming back. Others have modified this, gone further, and done what we call a Thompson procedure, where you will then excise a thin mid-lateral skin flap that you will then make along with your along the whole limb length, and basically you would then tuck it under What's the aim? Just trying to bring the superficial lymphatic in contact with the deep lymphatic system. There's many procedures. I mean, I'm not going to go into all. Holman's procedure, which is just a debulking procedure. You open, you debulk, then there are suction assisted techniques, as I've mentioned. But the ones now most commonly done are our physiological procedures. And what are our physiological procedures or techniques that we can use? We can do a flap transfer, just take a flap and bring it there. And that in itself can assist in draining the lymphatics. We can do a lymphatic bypass where we go in, we look for the lymphatics and anastomose them to each other. We can do a lympho, so basically you're looking for where there's the viable lymphatic draining channel, and then you go where there's the obstruction, you move that lymphatic, it's plumbing in essence, and you anastomose it to where there's better flow. And if you don't have that, you can do a lymphovenous bypass where you look for the you go along the groin, you take the lymphatic channel, and then you will then just anastomose it there, to the venous system, which of course you would have mapped the lymphatic using your dye techniques just to help, because it may be quite difficult to then see, and then you just anastomose it there in. And then you can also transfer lymph nodes, where you do a lymph node transfer and come and anastomose it around that region. Most often, some have been done with, concomitantly with breast reconstruction, and then doing a lymph node transfer therein. And these are just generally some of the techniques that may be then used that you can then mention. What are the complications? Of course, with your suction lipectomy, there may be abrasion that you may cause to the superficial nerves. You may disrupt the vascularity, damage other structures if you use sharp cannulas. And then resection procedures, you may have lymphoceles that form, wound dehiscence, infection, hematoma. And with our microsurgical techniques, you can also have lymphoceles and basically the same thing: wound dehiscence, infection, hematoma. And also just note there is a 2% risk of vascular thrombosis, and that should take care of lymphedema. I think with that we should be able to approach any case of lymphedema. I thank you for your attention. Goodbye.